Miss Elizabeth, will you introduce yourself, please?
Yes, ma'am. Hi, everyone. My name is Elizabeth Hooker. I'm an LPC. My background is working with trauma with survivors of domestic violence and sexual assault in children, adolescents, and adults. I'm trained in EMDR 1 and 2, and I'm from South Louisiana. Hopefully my accent doesn't come out, however, sometimes it does. And a random fact about me is I love to make gumbo, and I am actually cooking up a pot of it right now as I have a slight head cold, and that is my family's tradition of if you're sick, you eat gumbo. So gladly I'm turning it to you.
Thank you. If you guys ever call me Lester, I'll just ask who you're looking for and I'll try to help you find it. But I go by Wiley, of course. And don't let the baby face fool you. I've been in the mental health field for over 20 years now. And so some of my experience in the mental health field include being in private practice, working with kids, community mental health, where I served as a director of crisis services for a couple of years. This rollout for the state of Texas back in 2008. And I'm just happy to be here with the CPAN program now and present to you guys today. So I'm looking forward to today's discussion. All right, so again, I really appreciate you guys joining us. I know it's really busy for most people, especially during the holiday season, getting the last minute shopping done, waiting on those Amazon packages to come through. For the training today, part of the training or the training itself came about because of a few different things. One was feedback we received from providers about the need to address crisis in their office. And another thing is that through the CPAN program over the past calendar year to date, we've had over 20 calls related to the need for inpatient treatment or crisis need in the office. And so, unfortunately, we don't provide crisis services, but we do help quite a bit in linking doctors to resources like private hospitals as they call in. So we know that crisis is a big need to address that in the clinic. So we want you to provide feedback on today's presentation. We want to open discussions as we finish up today, and we cover the topics. So go to the next slide, please. So we really want today to be a very practical presentation where you leave today's presentation and you feel like you have the ability to develop and set up your own protocol or have some ideas about what you would like to do. So we want to really recognize some key elements in an effective crisis protocol, some things we feel like may be really beneficial, not just in a crisis protocol, but working with kids in your office. And then the second thing is to be able to implement it effectively in your office. That includes, communicating with people in your office universally, really concise, clear communication on what to do in a crisis situation. And then our specialty for me and Elizabeth with the CPAN program really is to identify and link providers to mental health resources. So that's going to be a big part of what we talk about today as well. We can move on to the next slide. So a crisis protocol is essentially just specific written instructions on how your office will address a crisis when it arises. So part of the reason this is important to address is that there can be a lot of confusion on what to do in terms of a crisis. So we're all in the helping field. And so the tendency is for people to stand back and let somebody else handle it, or everybody at once try to help jump in and help. So hopefully having a crisis protocol in the office for something that everybody has a guideline of what to do can really clarify roles. And so part of that is having something like I mentioned before, it's really a predictable response, whose role it will be in the office to address things as they come up. And then also, hopefully for you as doctors and nurse practitioners and physician assistants that see kids, to allow you to go back into your next visit with the kid and to free you up and allow you to continue to see folks in your clinic. So next slide. Why do I need a crisis protocol? First thing is you may not. You actually may have one in your clinic right now, which is fantastic. You may be joining us today for the CME credit and just wanting to know, if there's any additional information you want to add to yours, to your existing crisis protocol, or additional resources. So if you have one, that's great, and I appreciate you joining. So the second thing is you need a crisis protocol because your information currently is out of date. So we know over the past few years, there's been 2 different private hospitals here in East Texas that are no longer accepting kids and adolescents for inpatient treatment. So that one of those is the Behavioral Health Center inpatient treatment at UT. And the other one is in Greenville, Texas. So that was a regular go-to when I worked with the local mental health authority that I was with, that we would often refer to Glen Oaks in Greenville. So neither one of those are open for business or accepting any kids. So that leaves us with very, very few options here in East Texas in the 25 areas that CPAN covers. And so you may be joining us to update some information. The other thing is you may just need an idea of a foundation really to get started with your crisis protocol. So this can be different between clinics. So if you're joining us and you're a sole practitioner, or if you have just a few medical professionals in your office, it may look really, really different as far as a protocol than a larger clinic with several doctors or an integrated clinic. And so hopefully today, as we go through, we'll give some examples of really a foundation to where you can start with a crisis protocol and actually utilize it and put it into practice. So the third thing, or the last thing, as we'll cover today as far as why you need a crisis protocol is the stats really back up the need to be proactive. So we know one of the things that is really essential to addressing suicide is being very proactive, linking kids to resources and addressing crisis as early as possible. So for you as a professional to be prepared in your office, to be prepared to address these things as they come up is very important. So one of the stats that we cover on a regular basis for new clinics that we're enrolling is that 3 out of 4 kids with mental health issues present to their primary care provider for services. And so I don't have to tell you all that. This is something I know y'all see practically every day. And so the other statistic that really indicates a need to have a crisis protocol is a study by the CDC that looked at essentially a 10-year period of suicide across the U.S. And then more specifically for Texas, the suicide rate from 2009 to 2018 rose 47.1%. And I can provide that study to anyone that wants to look at it further. So there's a high probability and high likelihood that you will, if you have already not faced a crisis, that you will. And so we really want you to be prepared. So I'm going to turn it over to Elizabeth just to talk about how to actually create a crisis protocol.
Gotta hit that pesky mute button. So with this, we want you to take this with a grain of salt. We want you to, if you have a crisis protocol, you're welcome to kind of take these steps and look at it to see if what's jiving and what's not jiving. So one thing that I like to reiterate and remind people is communication within your office staff about crisis protocol in your office. So do you have one? Is it up to date? Determining a lead coordinator for the office. So this is going to be the person who is responsible for training the staff. It's going to be on the protocol, beginning to answer any questions in the event of a mental health crisis. You also want to identify your local mental health authorities and serving your county and the phone number of the crisis hotlines. And you want to document all of this information in your protocol. Second thing to kind of look at is identifying your psychiatric hospitals. So depending on where you are, Brentwood and Shreveport might be the closest to you, or Children's in Dallas might be the closest to you. So what are their phone numbers? How do you reach them? What is their intake criteria? And then you're going to determine the individual in office who's going to arrange for transportation to the hospital in the event of a crisis. You also want to document any backup plans for transportation. So are you going to call an ambulance? Or is law enforcement going to be involved? Are the parent and guardian going to take the patient? And who's going to stay with the patient while you're waiting for the local mental health authority to do an assessment or to transfer the patient to a higher level of care? This can include parent, legal guardian, family support, mental health worker, and then you want to document all that information in your protocol too. Another thing to look at is determine what staff member will provide follow-up after the crisis. So consider having one individual responsible for following up with the patient, and that includes scheduling an appointment after hospitalization. Another thing to look at is placing your completed protocol in your office in a prominent area that is easily accessible for your staff in the event of a crisis. You don't want to have to go digging for it. So look at posting multiple copies if you, have a larger office, or if you have staff members that can't leave the area. So for example, a receptionist at a front desk. So posting areas that include front desk, document stations, exam rooms, and in the break room. Finally, during a crisis, there's a tendency for a person and a professional to be stressed and more anxious, which can lead to confusion as to what to do. So having a protocol completed and posted can offer the sense of stability and have a response to a crisis to clarify staff roles and improve communication in the team. Also, one other thing that I didn't add in here is to, oh yes I did, check in with the staff after a crisis. You want to check in with yourself and with your staff. Your emotions are up here and you got to allow yourself to come back. So doing any grounding or deep breaths or just giving yourself 5 minutes to calm down, so that way you can go with a clear head into your next appointment. So we want to do this at this point is to give you an idea of what a crisis protocol can look like in your office, and we've adapted the Western Institute Commission for Higher Education's crisis protocol, and this is it right here. And again, it's I like this one because again it's straightforward to the point. It's one page and it's clearly defined in what information you need. And I know Wiley wanted to add something to the slide.
Yeah, so this is a PDF that has fillable sections if you want to use this directly. Obviously, again, we want you to customize it for your office, but give you a solid example. So one other thing to consider as you're developing the crisis protocol for your clinic, if part of that crisis protocol is to provide the family with crisis hotline numbers or information about how to access hotline numbers outside the clinic or after clinic hours, you want to make sure that it's understandable. It doesn't use a lot of heavy clinical terminology, and also, in several areas here in East Texas, there's large populations of Hispanic families, and so you want to make sure and offer this to and possibly, excuse me, in a Spanish version to the parents, not the crisis protocol, but if you're providing them with information about how to contact the crisis hotline. I know in my private practice, a lot of times kids would come in to my private practice that spoke English. They're actually bilingual, and so the parents did not. So I really try to adapt that to where the parents knew exactly what was going on in counseling. So the same thing definitely should apply as you see folks that may not be primary English speakers.
Thank you, Wiley. And again, this is straightforward to the point, and you just fill in what you need, and you can put a copy in their notes. Okay, so this is in our 25. This is all of our 25 counties that we cover, and each of them has a corresponding local mental health authority. This is included in the crisis protocol packet, and each local mental health authority has their own way of doing things regarding mental health, mobile crisis intake. So some of them, they will be in person, and they will come to the clinic if you call their their crisis hotline. Others will do it over the phone. Some of them will offer transportation. Some of them will not, and that changes regularly. So if the person that's going to be kind of in charge of your crisis protocol, I would check in with your local mental health authority every 6 months just to make sure that you're up to date on what's going on with that particular local mental health. And
I was going to add one thing. Yeah, thank you. So I was going to mention also with this is that if you have a clinic and your clinic is in Smith County, for example, your local mental health authority falls under the Andrews Center. And so you would call that location or call that, crisis hotline. But if you have and the patient's in your office at the time of the crisis. But if you have a family, a mom or dad or family member that calls you from where the patient lives, so the patient may live in Anderson County, drives into Tyler, which is Smith County. You want to make sure where the crisis is occurring to either call that local mental health authority, or if the parent's living again in Anderson County, you give them information about how to contact access in that crisis hotline. So that's come up actually in one of the calls before, where I'd provided information, but the child actually ended up being in a different county. So I wanted to make sure and clarify that as well.
Well, I'm going to turn this over to you.
Sure. So another concern that's we hear quite a bit from providers and doctors and nurse practitioners that call in is that there's definitely a concern for the patient they're seeing in terms of risk of harm, that the patient does not need immediate inpatient treatment, or maybe not even intensive outpatient treatment. And so what do you do during those types of situations where the patient may have non-suicidal self-injury, but is not saying they want to kill themselves? And so one of the things we wanted to talk to you about also is just a safety plan template. Elizabeth's going to expand upon this a little bit, but this will hopefully kind of address this concern that you have. We know that habituation can really lead to people taking more and more risk in terms of actually attempting suicide. And what I mean by habituation is that I know from personal experience, kids, teenagers that cut on themselves or have self-injury and it's never addressed and it continues and continues, they get more and more desensitized to actually the process. And so the risk of them accidentally doing something that's more lethal is a possibility. So I'm going to turn it over to Elizabeth to talk about some safety plan templates and some things we definitely don't recommend.
So first thing that I want to say is if you are still using no harm contracts, I want you to put them all in a pile and burn them. Roast marshmallows, whatever you want to do, burn them. When someone comes in and they're suicidal, we don't want them to be in a decision-making mindset. They're not in one, so why would we ask them to fill out a contract and have them sign something? So instead, we have a patient safety plan template. This is also in the crisis packet that we'll be sending out. Put your emails in and we'll send it out. And we also will be going over the actual packet itself at the end, so please stay tuned. So there are 6 steps when creating a safety plan. The first one is identifying warning signs. And you're going to do this with your patient. It takes about 5 to 7 minutes to do. So warning signs, and these can be thoughts, images, mood swings, or issues with behavior. Second thing to look at is coping strategies. So what can the patient do to take their mind off the problem without contacting another person? And this can include relaxation techniques or physical activities. The next step is people or social settings that they can use as a distraction. So for people, they're going to also write their contact information. And in all honesty, everyone has a cell phone. I would get the patient, I've had patients take a picture of it so it's on their phone. So if they lose the piece of paper, it's no big deal. It's on their phone. Also, when they're done filling this out, take a copy of it and put it in their file, just so if they call and say, hey, I lost it, can I have it? You have it. Another one is to identify people who the patient is comfortable asking for help. So if maybe they're not comfortable with talking to their parents, they can have a really, really good friend that they can reach out to. Professional agencies to contact, this can be a therapist, you as a PCP, or a crisis number. The last part is how to make the environment safe. So if there are guns, are they put away and in a safe? If there are pills laying around, are they in a place where the patient can access them, or are they locked up? If they need to get out of the place where they're in, and maybe they can go take a walk around their neighborhood if that's safe to do that, if they don't trust themselves in driving a car. So again, this form is not a contract, it's a template. You as a PCP are welcome to give this to your patient. We want you to give this to your patient to have them fill out, and it's theirs.
So one of the things, one of the other things to consider, I was going to just jump in here and just mention when you're writing or considering a crisis protocol, is that one of my experiences with the local mental health authority during my days in crisis is that providers would sometimes call us for a crisis situation, and they've sent the patient with the parents to the local ER for us to go out and screen. And so there's nothing inherently wrong with that. But one thing really to consider is that on a few of the calls that we received, the child was suicidal, actively suicidal. So you really want to know what if any plan they have. So if it is, I'm going to jump out of the car and kill myself on the way to the hospital, that would be really good to know. So you're not sending your parents outside of the clinic. So that goes back to the crisis protocol to really address roles in the clinic and what to do in situations when a crisis comes up. Another thing really that I thought about to consider when writing a crisis protocol, as me and Elizabeth were talking about this, is that obviously communication to everybody in the clinic, as we mentioned before, is super important. So we had a crisis worker that joined our clinic and she received full training. We had crisis protocol posted even within the mental health clinic, even though that's something we do every day, that's still something that we emphasize as far as training and it being visible. And so one of the things that she did was not follow the protocol in the training that was there for her. And so what happened was we had a mother and a 16 or 17-year-old, her son, come in with her. The new worker screened the individual, talked to mom, and then talked to the individual separately, the child separately, and then from there sent them on their way to the local hospital to get medical clearance. And so the protocol was to debrief afterwards, to staff the case, and then make that recommendation. So what we came to find out later is the son actually had homicidal thoughts towards the mother when he came in with. And so it's not enough, really just to say, here's the protocol and make sure everybody's trained on it, everybody's aware of it as you post that in the clinic, because there may be some that are just not comfortable. I think most people are not comfortable in addressing a crisis. It's very time consuming. So having real clear, concise, and consistent communication when it comes to crisis and crisis protocol. I'll hand it back over to you, Elizabeth.
And the only thing that I would add to this is document everything that you can. Okay, so some of the behaviors and some of the identifiers of a crisis can be, there's a bunch of different ones. So, and again, you can use this list for yourself, for your staff, and for your patients. So when looking for some of the behaviors, so behaviors in general, so there's an increase or decrease in energy and activity level. There may be an increase in alcohol, tobacco, and illicit drug use. There's an increase of irritability and outburst with anger or frustration, and they're frequent. And maybe they're arguing a lot too. They're having trouble sleeping or relaxing, crying frequently. They're worrying excessively. They're wanting to be alone most of the time. They're blaming others for everything. They're having difficulty communicating, or they're having trouble listening to people. they're having difficulty giving or accepting help is a huge one. And maybe they have the inability to feel pleasure or having fun. Now, there's some physical responses to stress also. So having stomach aches or diarrhea. I remember when I was a kid and I had a huge spelling test, I would have stomach aches every single Friday, and my parents couldn't figure out why, and it was because I was so stressed about those spelling tests. So having headaches or other pains, maybe you lose your appetite or you're eating too much, you're sweating or having chills, you're getting tremors or your muscles are twitching, and you have a very easy startle response. So emotional responses can include, but are not limited to, be feeling anxious or fearful, depression, having some feelings of guilt or anger, not caring about anything, and then feeling overwhelmed by sadness. And then the cognitive responses, so your thinking patterns. So you're having trouble remembering things, you're feeling confused, you're having trouble thinking clearly and coherently, and you're having difficulty making decisions. So there are all kinds of ways to relieve stress, whether it's affecting the body, your emotions, or your thinking patterns. And in the packet, we have 3 great examples that you can give this to your patients, staff can use them, and you can use them. One thing that I want to talk about or just touch bases about are physical techniques versus mental techniques. So your physical techniques are maybe butterfly. So you have the butterfly hug where you're concentrating on just this tapping sensation. Breathing techniques, again, it's your physical mindset. Mental mindset, it could be numbers. So I use counting by 3s because in the beginning it's easier, but if you get up in the higher numbers, it's a little bit more complicated. And then there's grounding techniques, and this uses all 5 senses. So I know in pediatric offices, you might have a little basket of toys or something like that. And in my counseling practice, I had toys of all kinds of stuff. So I have this little Beanie Baby, and I would get my kiddos to ground to it. Now with little ones, you got to remind them, please don't lick it unless it's a peppermint. Peppermints are great for grounding, but they can use all 4 senses to ground themselves to this object. And it's basically getting them to explain everything and anything about the object that you hand them. So it could be, there's little beans in here, it's soft, there's 2 colors, it's covered in cat hair, whatever they need, but it helps them regulate that self-regulation, because instead of getting stuck in that thought tornado of anxiety, it's pulling them out and their focus is on whatever is in front of them, whatever toy you hand them. So I know a couple of pediatricians, and they always have like a little stuffed animal in their pocket, and they would hand it to the kid and get them to use it. Let's see. Okay. Wiley, this one's for you.
Yeah, so we want to make sure it includes some hotlines. We're going to talk a little bit more about the local mental health authority hotlines for our area. We also wanted to include these 3. So one of the things you want to consider as you're developing that safety plan we talked about with individuals that they can take home is that they have as many options as possible, so they feel very equipped. There's so many doors open for them to receive help. So the calls that we receive are just a wide range of individuals as far as patients that providers call us about. So one of the things we want to include is the Trevor Project. This is for LGBTQ individuals and supports for that group of folks. So that it's not just the hotline that they have; they also have a text service as well. And so the other thing is we've had, I think, 2 calls in the past year for individuals that only utilize kids, actually only utilize American Sign Language. And so one of the things that we wanted to include is the information about how they can also access crisis services through Relay Texas, and then TTY. TTY is the text telephone, essentially. And then, of course, the National Suicide Prevention Line. As we talk about these, and if you add these to your safety plan with an individual, you want to make sure and clarify what
They may have
is going to
some
constitute
covered.
calling a crisis hotline versus 911. If they are in a situation where there's already something that they've attempted as far as lethality, they've taken an overdose of pills, they probably don't. They for sure don't need to call one of these hotlines. They need to call 911. And so you want to walk with them through the process and make that again the communication with them really clear on these. Now, I know from experience when we contracted hotline services, people would call and they've already actually attempted, took an overdose of pills, for example. So the crisis hotlines have protocol also on their end to deal with that and to contact medical staff and medical help. But you want to make sure and clarify these are for supports and having thoughts of suicide. You can utilize these services, and again, we'll go over the local mental health authorities as well. So I want to go over to the next slide if we could. So obviously, we offer the CPAN protocol packet. I've seen a couple comments already about it. So we obviously the packet includes everything we discussed today, including more information that we're not covering in detail. One of the things we also want to provide is that if you need just one-on-one consultation or suggestions from us, again, we want your protocol in your office to fit you and your specific needs. So you may not need the Lakes Regional's crisis hotline because you're not in an area where Lakes Regional is, or if you're in an area where there's high utilization of drug use, and you see that a lot in teenagers, you may be seeing, you may want to add something in that safety plan to give to individuals on resources, how to access if they relapse on drugs. So we can provide that support if you need us to come out to the clinic or just by video, discuss with you some things that we could that we would suggest in your crisis protocol. Please let us know. So I'm not going to exhaust this slide, but these are some things, and I think Elizabeth's going to pull up just some visual of actually what that looks like in the packet as I'm talking about this. But again, this includes everything we talked about. And I'll turn it over to Elizabeth to kind of talk a little bit about what you're seeing here.
Yeah, so first of all, I have dark mode on my Microsoft Word, so that's why it kind of looks a little funky. It's going to be a white background with the black wording, so please don't fret about that. So the first page of this is just introduction to the crisis protocol for clinical and individual doctors, and it just kind of goes over, what is included in this packet, and then it also has a couple of free material that you can use. Second page is kind of going over what we talked about in the presentation is, what is a crisis protocol, some statistics, what should be included, what else should you consider, information. So this is the steps to consider, and again, it's just for you to add on to your existing crisis protocol if you don't already have it. Again, it's that importance of communicating with your staff, identifying your psychiatric hospitals, who's doing follow-up, protocols, and then checking in with you and your staff afterwards. This is the office protocol that was on one of the slides, and again, easy peasy. You just fill in the information and you're going to be able to either print it off if you want to do that way, or it'll have the electronic fill-in too, and you sign and date that. This is the local mental health authorities, crisis line and main line, and then the counties that they serve. So this is all within your fingertips, and it's got, again, the crisis line and the main phone number. With the crisis line, they're supposed to get back with you within the hour. With the main line, it's 24 hours. So be aware of what number you're dialing. And then we also have some other numbers to add to your list as well. These are the inpatient options that you have, and the phone numbers to the intake, and they also have the addresses. These are the ones that we've had contact with, and they're pretty speedy on telling us, hey, we have beds, hey, we don't have beds, if you want to just go ahead and start calling people. I will state that if a PCP or office manager or somebody within the office staff calls, you're more likely to talk to a person and not to an answering machine. Not saying that you might go to an answering machine. I'm not, that does happen, rather than a parent calling. Unfortunately, that's just the case on some of these. The next one is, again, your patient safety template, and it's got lines for you to fill out everything, the numbers, and then one thing that is the most important to me and worth living for, I think is very important in a crisis setting, just to get them onto a positive. These are my cheat sheet questions that I've kind of created. So it goes along with your patient safety plan template, and each of them are numbered. So for example, step 1 is the warning signs, and it's different ways of asking about warning signs, because I know for when I had a patient come in who was suicidal, I was deer in the headlights. Like, I had no idea what I was doing. So I created this list of questions to kind of jumpstart my brain of, okay, these are some of the questions that I need to ask. And it's for all of the different sections on there. And again, use what you can. If you don't want to use it, don't use it. This is, the next one is the different techniques. So I've got grounding technique, and it uses all 5 of your senses. You don't have to use all 5 of them. If you just want to use, things that you can see, feel, and hear, that's perfectly fine. I like this grounding technique because you can mold it to whatever you need it to be. Breathing technique, I really like this one, especially when I'm like having a panic attack, or one of my clients is having a panic attack, and it's just that it's called 4-7-8 breathing technique. You can play around with the counts. I encourage you to play around with the counts, because if you're somebody who is very, very active, you can hold your breath for a little bit longer as long as it feels comfortable. You are not straining, and that is important to remind your client. You should not be getting red in the face. And then this is another one where they can cut it out and they just turn. So you inhale, 2, 3, 4. You hold, 2, 3, 4. You exhale, 2, 3, 4, and then you rest, 2, 3, 4. And I really like this one because you can just turn it, and it's, again, something in their hands also. And then that is the crisis packet. And then go ahead.
I was going to mention on the safety plan that you developed with the client. One thing that definitely recommend is that you do that collaboratively. I know your timing is extremely tight as providers. So if there's a possibility of going through that collaboratively, having the patient actually write some things. If they're too young, if they're too small, absolutely, bring the parent in. You always want the parent involved in these safety plans so they're aware. But if the child's old enough to participate, have them, talk to you a little bit about some of their supports and make that collaborative. It's much more of an impact if the patient's, my experience, if the patient's involved versus just being told to do something. So if they come up with some ideas, I know meeting with kids before, they come up with some very creative ideas on how to address their own symptoms sometimes. So having that is I think very important if time permits. So.
And we've timed this. It takes about 5 to 7 minutes to complete this. So again, if you can do it, great. If maybe a nurse can do it, or somebody, whoever your crisis protocol person liaison is, if they can do this, then again, it's that relationship building. They're not alone is the important thing.
Okay, so one of the things we talked about, we really wanted it to be collaborative, and we got a very cozy amount of folks on the call today. So I would love to hear if anybody has any feedback or any experiences, any of your personal suggestions on things that maybe use in office that maybe your peers on the call today could find helpful. And then I'm going to open it up for that after I mention for the packet. Probably maybe the easiest way is just to email us directly. We'll get your email and send that right back out to you as far as the packet if that's something you want. And you can use this email at cpaninfo at uthct.edu. So I'm going to open it up. Anybody have questions or comments?
And then also, this is Laura. One of the things that you can do if you are a provider and you're requesting the CME credits, you can also put that request in there. There is a section where would you like the information about the presentation. So I've taken some emails, and there's also another process there for you. So absolutely. So we do, as Wiley said, we encourage you to share today. We've got quite a variety of provider types and clinic staff that are on today's call. We know here in Texas that we have a need for support for children and adolescents who are having suicidal ideation, who are really struggling with depression and anxiety and not knowing exactly what to do. The Surgeon General just had an advisory that just came out this week that talks about this. So please share if you would some of the things that you've seen in the clinics. How do we help you? That's what our job is, and I'm going to open up the floor right now.
I was going to share, just as people may be thinking about some questions or things to share that they have in their own practice. One thing I was going to mention is that part of the crisis protocol that we had talked about, one of the calls I've received here recently, and I know from experience, crisis in general, the adults or kids, can be very time consuming. And so a call here recently I had, I think I called around 4 or 5 different hospitals trying to find just bed availability, see if it was open for the provider that was calling. And so so having that information, and then I turn around and pass that information on to the provider after I called. So having that in office available to your staff and kind of, not necessarily having to call us. If you need to call us, that is our job. Our job is here to serve you and provide resources to you. But if you could bypass us and go straight to one of the hospitals that are listed in the packet that Elizabeth talked about, also that may cut off some time for you in terms of seeing folks who've seen patients there in the office. So so part of the protocol is to make things really streamlined and hopefully flow a little bit better and smoother for the clinic. So I'm gonna shut up now and see if anybody has any questions.
Wiley, I have a question while others are thinking of them. Let's say that I am a provider in a small clinic. Let's just say that there are there are 2 of us as far as PCPs, and we're just a small practice. And what if I have a patient that started cutting herself and then began to cut more deeply and more deeply, and now it's not just I'm just cutting to cut for release, but now it's I really don't want to be around anymore. How do I address that as a provider? When should I be afraid of them actually using that as potential suicide? And what do I do if I can't get that patient in?
Yeah, great question. So, and that's not an uncommon thing that of course we get calls about. So one of the things I want to kind of reiterate what I mentioned earlier is being very proactive. So just because someone is cutting initially doesn't necessarily mean they're always wanting to kill themselves, and we know that, and we share that with providers too. But I think having that safety plan that we talked about earlier, that's available in that in the packet, have that available for not just here's some crisis hotlines to call, but here's some coping skills that you and I collaboratively have talked about. Are you using those? Are they helpful? If they're not helpful, let's review those. Another thing really to think about would be using CPAN to really link some of these kids or teenagers to counselors, so they can have some support very early on, early intervention. Again, I can't emphasize that enough in terms of lowering the suicide rate. So if you have a counselor, the safety plan, you have people invested in your treatment, you have hope, or you can at least can see some hope, even if your perspective is that there's none. And so one other quick thing you mentioned, as far as if the cutting progresses over time and it gets more and more and more. What I was talking about earlier was habituation. And habituation is something that can lead someone's used to cutting on themselves, and it's repeated and never gets addressed. There is cases I can think of in my time in the mental health field where they go too deep in cutting, and it's an artery. It's something significant on their leg, on their neck, on their arm. And so again, being proactive, having these things off as early as possible, opening as many doors as possible, and linking them to services as early as possible is really going to be key.
Thanks, Wiley. Do we send these kids home? I think that's sometimes as a provider, let's say I can't get them in right today. There's just, as they say, there's no room at the inn. What now? Can I send them home? If so, what do I tell these parents?
Yeah, that's another great question. So that call I received here recently, actually, that was the case. And so 5 calls to 5 different private hospitals, none of them had availability until the next day, or I got an absolute no. There's no openings right now. And so how that resolved, how that case kind of resolved itself is that there was a really clear written instructions on, okay, you are going to present at the hospital that's available for admission tomorrow morning at 9 a.m. As you leave the clinic. Now, I would never encourage and never condone if someone's actively suicidal. You still have the backup of the local mental health authority to come out and provide a crisis screening and utilize more state services, state hospitals. But we know that notoriously those are often full, and there's a wait time for those as well. So, but having a safety plan in place if the child's not an imminent risk, but needing hospitalization, so the parent is aware. The parent also takes anything out of the home or locks things up at home that are potential tools for a suicide attempt. So medicines, guns, knives, objects, razors, just anything that's going to be potentially used by a kid until you can facilitate that again, in my case, the next morning, driving the child for that intake for the hospital.
Thanks, Wiley.
And just one quick thing. So the world is definitely not black and white. You send them to the hospital and there's someone that's suicidal. These are real, and the folks that are listening today, I'm sure know this practically too. This is real world. Sadly, there isn't always a bed somewhere that's available to send a kid to. I remember working with LMHA. In all state hospital, and I was in Northeast Texas. All the state hospitals were full except for one, and that was in El Paso. And so, it wasn't realistic to drive this kid all the way by the sheriff's department or an ambulance, hours into the next time zone to get treatment. So there had to be a plan in place to keep them safe before admissions.
Any questions from the group on the call today? All right, two things. One is if you'd like more information on a crisis plan, please feel free to give us a call. We would love to be able to support you with that. If you're in Northeast Texas, the 888-901-2726, option 1 and option 3, just remember 13, and you can get directly to Elizabeth Bailey. I also put a little note in the chat, but we have a couple people that are just on the phone. This is Laura Young. As I mentioned, I had commented on the Surgeon General's advisory on child, adolescent, and young adult mental health that just came out. If you would like a copy of that, that advisory has quite a bit of information on there, things that can be done by clinics, by businesses, by health plans, by families, by community agencies, all about addressing child and adolescent and young adult mental health. Please let me know. You can put your name in the chat, or you can email me, and I'll get that sent off to you. I downloaded a PDF of that, and I think you'll find the information and the statistics quite interesting. All right, Amber, I will get that sent off to you. All right, I'm going to go ahead and place the QR code up here for you all so that you can get your continuing education credits if that's if you are so inclined. I'm going to leave the phone open, and Wiley and Elizabeth and I'll be hanging on here for a bit so that if you have a question, you can ask it. We'd be more than willing to answer that. If you're in Northeast Texas and would like to schedule a time for one of our therapists to come out and work with you on a crisis plan, that'd be great. We would love to do that for you. We can do that again in person, or we can do that over video if you would like. And I am still trying to bring this up. My apologies. There we go. There's your QR code. You can use that QR code, or I'm going to place the, oops, really I am. I can also place the evaluation link in the chat, and you can use that to complete your code.
I did that for you already, Laura.
Wonderful. Thanks, Stephanie.
You're welcome.
Stephanie part of our awesome CME department. That's Stephanie Williams and Meredith Burks. Without their support, our CPAN CME would not be what it is today. So thanks, Stephanie. So I will share with you, we do have another CME coming up, and that is the beginning of January, so 2022. On January, let me check, January 4th at 12 noon, we will be conducting a pediatric grand rounds for one of the health systems here in Northeast Texas. That's Christus Trinity Mother Francis. And that pediatric grand rounds will be on non-suicidal self-injury. If you have not received the link for that yet, and you are enrolled with CPAN in the Northeast Texas area, you will be receiving that shortly. If you are interested and you're outside of our area, you can certainly send us an email at cpaninfo@uthct.edu, and we will get you added to that. Our speaker for that is Dr. Nicholas Westers out of UT Southwestern, pretty incredible psychologist and professor for them. Just has a wonderful knowledge in the area of non-suicidal self-injury, and there was a special tool that he developed for assessing that. I think you will be pleased and be glad you joined us for that. All right, for those of you that are still on the call,